Hi guys, welcome back to the channel. I'm continuing again today with my face restoration colleagues, Dr. Rachna and Dr. Jonathan, and we're going to be talking about today lower blepharoplasty. So tell us, what is it?
Lower blepharoplasty is basically the same as an upper blepharoplasty, where you're trying to reduce the amount of saggy skin at the top lid, but here at the bottom lid. But the anatomy is slightly different, and so the surgery is slightly more complex. You might choose to have a lower lid blepharoplasty, either because your septum has become weak and your fat can start protruding out. So that might be one reason to have a lower lid bleph, to tighten the tissues. And then also you can end up with things called festoons, which is sort of where the skin becomes lax and starts hanging down. And some older people will even have that fill up with water sometimes. So you might want to tighten the skin, or you might want to tighten the structures underneath. And sometimes when we do a lower lid blepharoplasty, we actually have to do a combination of things and reposition the fat as well.
In the lower lid, we are dealing with more effect from gravity and the effect from aging as well. So what we are trying to do is reverse those changes with our surgical approach. And we do that from either the inside of the eyelid, so the inside surface, or from the outside with a skin incision. And that decision to go from the different approach depends on what it is that is the main problem. So some people who will have excessive skin, we would want to make an incision in the skin to remove some of the excessive skin. For those people who have more of the fat prolapse without excessive skin, then we can make a little cut on the inside of the eyelid to approach the fat, which sits underneath the skin and the muscle. And both of these approaches leaves you with no visible scars. It's not as technically straightforward as the upper lid area, and there's a little bit more downtime. But it's a very good and effective operation for reversing some of the aging changes that we see.
I think these are the most common operations that oculoplastic surgeons do, upper and lower lid blephs. And you can have all four done at the same setting as well.
Oedema is something that is not uncommon, and oedema can happen for medical causes as well as from previous treatments. So previous filler that has been done not so well, or too much of it, can cause oedema. And oedema is basically fluid within the structure of the lid and underneath the skin. And what we have is something called a lymphatic channel, which drains fluid away from muscle and from the structures underneath the fat. And those lymphatic channels drain away towards the ear area. And so anything that blocks those lymphatics or delays the lymph drainage can cause edema. So medical conditions can cause swelling and puffiness. So certain things like thyroid disorders, so an underactive thyroid, in young people as well as older people, so you don't have to be an old person to get edema. Treatments like hyaluronic acid fillers given in the wrong depth, in a superficial depth, can delay the lymph drainage. So that means that you can get fluid that becomes saturated within the lid tissue, and sometimes the only way to treat that, if it's not dissolving the fillers that have caused the problem, is to remove it with surgery. So in terms of our lower lid blepharoplasty surgery, we will very often be able to try and improve the edema, particularly for some people who have had a lot of filler to the area that has caused this build-up of fluid. And we can do that with blepharoplasty.
So I get asked a lot, if somebody's going to have a lower blepharoplasty, do they need to have any filler removed that they've had placed before?
You don't have to have filler removed. An option to reduce swelling, and there's been a paper that was published by one of our colleagues recently, and one of our friends, that demonstrated that actually before going down the route of blepharoplasty, dissolving some of the filler can mean that they don't need to necessarily have a blepharoplasty operation. But on the whole, you don't have to dissolve filler before you go down the route of blepharoplasty, no.
When you place your filler, Sarah, you place it in a very specific location for a specific purpose. as the body has then changed over time, that has ended up in the wrong place or has moved or migrated. When we then reposition the tissues, it's not necessarily the case that that filler will end up in a good position. And so that's where you then have to judge it and say, actually, that doesn't look right, and remove it.
Something else that I've heard of is when patients have hyaluronic acid removed around the eye, but because they've got edema, but then the edema is still persistent once all the product has been removed.
So that can happen. It's rare, but it can happen. And one of the reasons for that is that the hyaluronic acid sits within the tissue that structures in the eyelid. And the lymph channels that drain the fluid away are obstructed. And so when we're targeting the hyaluronic acid with hyaluronidase, the enzyme that dissolves it, you're not always going to get that pump mechanism of pumping the fluid away from the eye straight away. There is a time delay, time lag. So our eyelids are surrounded by this circular muscle that's called the muscle pump, or the lacrimal pump, that pumps tears, but it also pumps fluid in the lymphatic channels away from the eyelid area. And so there is often a time lag when the edema will not settle down straight away. In addition to that, sometimes the hyaluronic acid gets integrated into the muscles itself as well, and we get something called saturation of the hyaluronic acid in that area. That means that the product itself, even though you're dissolving it or attempting to dissolve it with the enzyme, doesn't all go. So it can be within the muscles. And there are new studies that are coming out that are looking at this, where they are finding that there is product within the muscle that's retaining water and retaining fluid. If people are worried about edema and it doesn't go with the hyaluronic acid, there are ways and means of dealing with it that can improve it in the vast majority of people. And sometimes that does involve surgery to remove the saturated muscle that's full of hyaluronic acid.
Interesting.
And by repositioning things so that they're higher up, you can then get gravity helping to remove some of the fluid as well. So surgery can be helpful. And I think what we're also seeing when we looking at the kinds of patients who come through with complications from this often have older fillers that were placed a long time ago. So when people were placing things like silicone and others, some patients come to us and they don't even know what they've had placed. And I think usually it's those sorts of substances where we see chronic indurated, like hard masses or masses that are causing real problems. With the hyaluronic acid, I don't think that's something we see as much. The really bad cases that we've seen have been these older fillers, or where people don't know what they've had, or it's come off, some back alley somewhere where it isn't actually a properly produced product.
Absolutely, that's really important. I mean, it's really important to go to somebody who is experienced and good and dealing with the right products for this area, and then you shouldn't run into those problems.
So if someone is getting a bit of ectropion, would that be covered under a lower bleph sort of procedure?
Absolutely, yeah.
When you reposition the tissues, sometimes what we like to do is, because you're going to have a bit of post-operative swelling, that itself can pull the lower lid out. So often what we do is we try to do a belts and braces approach. So we put in something called a canthopexy, and that just strengthens the lateral angle here, the outer angle of the eye, for a time being. It's not a permanent procedure, but it's enough to keep the tissues in the right place while the healing process is going on.
It's a really good question, because a lot of the non-surgical approaches to the lower lid will not do a canthopexy. All surgical blepharoplasties will have some form of support, and unless the lid is assessed beforehand, most doctors and practitioners will test the lid tension and see whether it springs back and make sure there isn't an ectropion already before treating non-surgically in the lower lid. And if that's not done and there is an ectropion, which is the lid turning out or the lid's loose, then you can make that worse with the treatments. But when we do the surgical treatment, we always strengthen that area. It's really important to do that.
Let's talk about that actually. So how would you strengthen that area?
Yeah.
Well, there are a number of different ways we can do it. Sometimes we remove a bit of tissue to tighten it, and sometimes we change the position of it, so raise it. It depends why it's loose. So sometimes this is a very delicate structure on the side where things are attached, and it's important to get it at the right level. If you place the lower lid too far forwards, you can actually get evaporation and a dry eye. So sometimes, in order to tighten the lower lid, we might remove a portion of the central part of the lid, which again heals without much of a scar at all. So there are different approaches, and what we like to do is we like to address it where the problem is. So if somebody has a loose lateral canthus, we'll operate there. If somebody has a loose middle lid, we'll operate there. And if somebody has a loose medial canthus, we can also tighten the medial canthus. And so there's a tailored approach to that. So just talking about this ectropion, when the lower lid turns out, it's not always because the lid is loose. So sometimes you can have scarring that can pull the lid out as well. And so it's not a one-size-fits-all. Just because you have a lid that's showing red at the bottom here, it doesn't mean that you need a tightening. Sometimes we actually have to put skin in. One of the saddest cases I've seen privately was someone who'd had a lower lid blepharoplasty, and rather than supporting the tissues, they'd removed a lot of the skin. And so this person, who was otherwise, a young, beautiful woman, was no longer able to close her eyes. She could close her upper lids, but the bottom lids, the lower lids, wouldn't meet the upper lids. And so even though in a static position she looked good, it was not functional. And so it's important that this is not, a lower lid blepharoplasty is not just a remove the skin procedure. We know from your mentor's work, Murthy, that treating with non-surgical approaches can actually alter the position of the lateral canthus. So you don't have to have surgery in the first instance. And I would say, why go have surgery immediately? Why don't you try with fillers first, see what kind of result you get, and if you're able to just elevate the canthus, that might be enough to keep you going for 4 or 5 years, at which point the skin will be a little bit looser again, and at that point you might then go for some surgery, and then you might go back to some non-surgical approaches. So I don't think it's a one or the other, it's a combined approach.
I had that done, actually.
Which one?
I thought it was good. Kish did it for me. That's just an aside.
No, non-surgical.
Yeah.
Because I was thinking there's absolutely no scar at all.
Yeah, no.
He's obviously a very good surgeon.
You can absolutely
Well done, Kish.
You can strengthen without surgery. So yes, you can lift without surgery, and you can improve muscle function without surgery.
If you go see someone who removes too much skin, at that point it's very difficult, because you either have to manage to lift enough face to give you some skin back, but most commonly what we have to do when somebody's basically made a boob and removed too much skin, we have to put new skin in. So we have to take skin either from the upper lid or from behind the ear or from just in front of, we have to find skin somewhere and we have to put it back in. And once you had a skin graft, we do amazing work with flaps, moving skin around from the local area. Once you have to take skin from somewhere else and put it in, it can look okay, but it just, I don't think you ever get that really unoperated look. And that's what we're looking for. I mean, ideally, once you've been to see a good oculoplastic surgeon, people should not be able to tell that, oh, you've had surgery. I mean, that if that's the case, you've failed.
Well, you know what they say, measure twice, cut once, right? Okay guys, so that's all we've got time for this week. I hope you enjoyed the videos. Join us again next week. We're going to be talking about something really hot, which is blindness after dermal fillers. See you later.